Well, hi, everyone. Again, welcome to another Shop Talk. Today, we'll be discussing two papers, and they're both from 2023, and they're both from Dr. Patrick Knox. And one is from Pain Medicine, the other is from the Journal of Pain. The titles of the paper are Construct Validity of Movement-Evoked Pain, Operational Definitions in Older Adults with Chronic Low Back Pain, and Movement-Evoked Pain versus Widespread Pain, a longitudinal comparison in older adults with chronic low back pain from the Delaware Spine Studies. So Pat, thank you for being on Shop Talk. Can you start by just telling us a little bit about yourself and both, your clinical side or your research side or whatever you'd like to share?
Yeah, absolutely. And first, I wanted to thank you for the opportunity to be here and talk through some of my research. Really looking forward to it. So as you mentioned, I'm a clinician scientist. So I first completed my DPT training at the University of Delaware, and that was roughly in 2018. And thankfully, I was able to get put onto a T32 grant, which allowed me to transition directly into a PhD, again, at University of Delaware. And I had the great pleasure of working with Dr. Hicks, and primarily his research in his lab is focusing on geriatric chronic low back pain with the overarching goal of trying to get a better sense of who's most predisposed to disability and health decline. So that was the majority of my doctorate research training. And I will say that my early research focused more on that same research mission as Dr. Hicks, who was mostly looking at predictors of disability and fall risk in that population. But later on, I transitioned more into movement-evoked pain, which of course we'll talk about today. And also my dissertation work was focusing on looking at pain sensitization factors, so quantitative sensory testing and things like that. Currently, I'm a postdoc in the labs of Dr. Michael Borich and Dr. Lena Ting, which is at Emory University, and they study slightly different topics. So Dr. Borich more so is working on neurorehab and neuroplasticity in post-stroke populations, whereas Dr. Ting is working on the neuromechanics of balance. So it's a really cool blend of different research topics. And we also collaborate with Dr. Dan Harper, who's in the Department of Anesthesiology at Emory, and he runs the Psychophysics and Imaging Research Lab there.
Wow, that's a great lineage, great training background. So you mentioned movement-evoked pain. You had those two papers that were published on that. I think it's probably a concept that most individuals aren't familiar with. Do you mind just defining it first and giving us your perspective around it?
Yeah, that's a great question. So I think it's probably best to start off by saying there is no one agreed upon or operational definition here at this point in time. But there was a recently proposed definition from Fullwood and colleagues. I believe it was published in 2022. I want to say the Clinical Journal of Pain was the actual journal, but don't quote me on that one. But generally, they were saying that it's this instance where pain is provoked and experience in the context of active or passive movement of the injured or involved tissues. So I'm not going to say that that's the only definition we should think about, but it's a good starting point. And I think there are some other considerations that you can take into account, such as psychological distress factors, which can be general, such as depression or anxiety, or they can be pain specific. So pain catastrophizing is a great example there. And then also you can think of other factors like pain sensitivity, which is what my dissertation focused on. So there's a lot of things that are kind of swirling around at the same time that can all influence whether or not somebody has large or small instances of movement-evoked pain. Yeah.
So it's multidimensional, it sounds like. And if I'm correct with that, if you're looking at someone in the clinic and you have a suspicion they have movement-evoked pain, what are the things that you look for?
Yeah, great question. So it's tough to give really broad generalizations because this really does vary quite a bit, and we're just starting to understand what it actually looks like. But a couple of obvious examples would be an older adult who has knee osteoarthritis, and they might experience particular bouts of pain, whether they're going through a certain range of motion, a certain weight-bearing scenario, or a certain functional activity. So it could be rising out of a chair, using the stairs, scenarios similar to that. And then more specific to my work, if you're working with an older adult who has chronic low back pain, they could also have pain in similar scenarios. So during weight bearing, during walking, getting out of a chair, using the stairs, walking for prolonged periods. So it's really this particular instance or experience of pain that is directly adjacent to a movement experience. So it's a change in their baseline pain ratings that's directly linked to whatever activity they're going through.
Gotcha. Okay, thank you. And I know you work with the elderly population. How prevalent is it in that population? And is there another population outside the elderly that you're aware of that we might also look for that in those patients?
Yeah, it's a great question. So it's tough to give an exact metric or figure here because I don't think it's really been captured quite well up to this point in time. And part of the issue there is that there's a lot of terms you could see that relate to movement evoked pain. So I think people are currently trying to address that issue with research. But anecdotally, I would say that movement evoked pain is really common, and it can often be a defining characteristic of many chronic pain populations that are older in age. As far as other populations where you might see it, I would say the most well reported out of those would be fibromyalgia. So it's a really obvious case where you could have somebody that's experiencing pretty frequent flares in pain when they're moving. Certainly the CRPS population could also experience this too. So it's not just bound to a specific age group or a specific condition. It's more so something that can happen pretty frequently in a lot of different conditions.
Yeah, that's super interesting. I had thought beforehand, before I started reading about it, that it would be less prevalent. But after reading your work and others and talking to Corey Simon, I think, who was a co-author on your paper, it's more prevalent. So I have to ask you this question. I mean, we're the profession that moves people, right? Motion is the lotion, et cetera. How do
Sure.
you reconcile, kind of the key principles of what we're about to the identification that some people movement is the thing that triggers their pain? Can you give some suggestions around that conceptual dilemma?
Yeah, it's certainly something that we've wrestled with quite a bit. So it's a tough one to answer because we shouldn't be fully avoiding instances where somebody's experiencing pain because I think that can have other negative consequences. So if we're starting to cultivate this fear of a certain movement or a certain set of activities, I don't think that's a great way to go. So it's probably better to think about it in the context of identifying when there might be more frequent exacerbations and potentially introducing those things more gradually in a given person. So everyone is different and everybody's biopsychosocial influences are different as it relates to pain. So it's one of those individualized questions where you just need to identify when somebody is frequently experiencing pain, noticing whether or not that's really driving their specific type of disability or not, and then you can make decisions thereafter. So if you think that this is a person that's directly struggling on given activity or given movement, then maybe it's not best to start with those. But I think over time, you should be eventually working those into your specific goals and getting people back to full and unrestricted movement as best as you can.
All right, super helpful. So I am really interested. You said something that resonates with me is that people all present differently, right? They have different pain mechanisms. They have different classifications of pain. There are different reasons behind the pain that they have. And we've done a little work on the IASP pain mechanisms piece, but what was it that really drew you to this type of work? What was the provenance, or what made you interested in it? Was it serendipity, or what, did you seek it out?
That's another great question. So I think part of it was my desire to continue on with Dr. Hicks's research mission. So we're always striving to find the most impactful or deleterious consequences in that geriatric chronic low back pain population. So we've always tried to think about how can we best identify the facets of pain that are most limiting in this population. So I think that was probably the background to this. And part of it was also my strong interest in pain mechanisms. So we were trying to get at the fact that there might be this distinct population who's more susceptible to feeling movement evoked pain. Now, it's a little tough to say at this point in time whether that's more of a nociplastic pain presentation or not, but just generally you can think of it as somebody might be more susceptible or not to this flare in pain. And from there, when we looked into this topic, it was pretty clear that there wasn't a lot of work done in older adults with chronic low back pain. And I would say in the geriatric population, most of the work had been done in knee osteoarthritis. And this wasn't really a new finding for us because this group is routinely understudied, even though they're the most susceptible to disability and health decline. So it just seemed like a natural next step to get a better sense of whether or not this construct of pain was clinically meaningful and, should we further study it or not? That was kind of the thought there.
So that's a great segue into your first paper where you looked at construct validity around this. Yeah, I know that everybody's heard the term construct validity. Do you mind defining it for the listeners?
Sure. Yeah. So when I think of construct validity, I would define it as the extent to which your test or measure is accurately characterizing or assessing the factor or construct that you're interested in or trying to get a better understanding of. So in this context, we're of course looking at movement evoked pain. And with this particular type of measure, it's difficult because you're looking at the interface of pain and movement. So there's a lot of things that you have to take into account. So in our mind, when we were trying to put this study together, we were thinking of the types of movement that may evoke pain because, again, everybody is different. So you can't just pick one individual movement and hope that that will really characterize this type of pain in a large population. You also have to think about when you're assessing pain. So should you assess it before and during and after? There are a lot of questions there. And then lastly, how are you actually going to define it or calculate it? So there's a number of ways that you can arrive at these different types of movement evoked pain definitions.
And I think in your paper, you mentioned that it's commonly measured or defined two different ways, and you measured those two different ways that it's measured long-term to different self-report outcomes and a physical performance battery, if I remember correctly. Can you talk about what you found with that and which way that it was defined or measured was the one that was most associated with those longer-term outcomes?
Yeah, so in that first paper, we were looking at two of the major definitions. I will say there are others because this has been coined a lot of different phrases over time, and it's difficult to capture all those different definitions in one study. But the two that we focused on were delta scores or change scores, which is where you would subtract a pre-movement rating of pain from a post-movement rating of pain. And the other one that we looked at was an aggregate score. So you can just think of that as summing the post-test pain ratings. Now, it might seem like a fairly small distinction, but if you think about having an individual who's had chronic pain for a long time go through several different functional tasks, it's possible for there to be pretty variable pain behavior across them. So if you take the simple scenario of somebody starting at a 2 out of 10, after a given task, let's say getting out of a chair, they might end at a 5 out of 10. And then immediately afterwards, with a little bit of rest, they're going to then start another functional task, which is also part of your measurement of movement evoked pain, right? So it's not a guarantee that they're going to start again at a 2 out of 10, which was their baseline. So in our mind, that raised a fairly obvious question of, well, is it possible that using change scores is not the best way to capture this burden of movement evoked pain? So that's what led us to look at the aggregate scores. So generally speaking, in this first study, it was cross-sectional. So we were looking at these two different definitions of pain, and we also had a couple of covariates that we included in our regression models. And our outcomes were perceived disability, low back pain related self-efficacy, and then also a functional measure, which was the Health ABC Performance Battery. And generally speaking, the aggregate score was a superior measure of movement evoked pain in the sense because it was more strongly related to each of these three outcomes.
Yeah, my apologies. I said long-term and it sounds like it's cross-sectional. So well done describing that, by the way, and why clinically that is meaningful. So and I know you're being beaten to death in your postdoc right now, but if you were in the clinic, would you look at the aggregate score then when evaluating a patient and their response to movement based on the work you did?
Great question. So I think there are a couple of things to keep in mind here. So there are a couple of avenues you can take. So in our studies, we were using standardized functional tasks to potentially elicit pain. And the idea there is there's a strong clinical relevance because you're obviously getting a sense of their physical function and their overall mobility capacity. But at the same time, with only a few additions to these measurements where you're just asking about pain before, during, and after the assessment, you're able to then calculate movement evoked pain. So you're not really having to change much in clinical practice, which is why we went that route. So in that case, if you're using several different measurements, and in these studies, I should also mention this, we looked at the repeated chair rise task, the 6-minute walk test, and also a stair climbing task where they had to go up and down a full flight of stairs. So as I mentioned, there can be quite a bit of overlap if you're looking at several different functional measures as far as the pain ratings that you're capturing. So in that case, if I really had to pick, I would say that an aggregate might be superior, but a safe way to cover your bases is to capture pain before, during, and after. And in that case, you can look at either measurement. So it could be a change score, or it could be an aggregate, and you can keep things standardized within a given individual. Now, the other option you could opt for is using something like the PSFS, which would give you an individualized sense of what bothers somebody as far as a functional task that elicits pain. Now, the upside there is it's very tailored, it's very individualized, but the downside is you might not be able to use a standardized functional measurement like the chair rising task. So it might be reaching that affects a given person, or it might be crouching over to lift something from the floor that affects a given person. So as long as you can standardize an activity, even if you were to use a more individualized approach, I think you could still use change scores or aggregate scores for movement evoked pain.
Okay, that's useful. Let's talk about your second study. And in this second study, you actually looked at movement evoked pain and widespread pain. And I believe you looked at an evaluation out to 12 months on disability measures and a number of other things. Can you tell us the reasoning behind? I mean, we've all been indoctrinated into thinking that widespread pain is a negative prognostic factor. I mean, was that the reason you included that as well as movement evoked pain to see which of the two were most associated with disability?
Yeah, so this one was really rooted in clinical relevance because, as I mentioned, there's a lot of different facets of pain that can impact this population. So we were trying to whittle away at this and get a better sense of what's really meaningful here, what should people be using in the clinic, and also what should drive future research, because ultimately resources are limited both in the clinic and for research for different reasons, but still limited. And we're trying to get a better idea of what is actually important here and what should we focus our efforts on. So as you mentioned, widespread pain has been pretty consistently linked to poor outcomes, not just in chronic low back pain, but across the board. And our idea here was to try and determine, in a relative sense, whether widespread pain, movement evoked pain, or even resting pain, which is probably the most common of these three measures, which one of those is actually the most important in regards to long-term outcomes in this particular patient population.
So what did you find, if you don't mind?
Sure. So generally speaking, we found that movement evoked pain at baseline was the strongest predictor of perceived disability and pain-related self-efficacy at 12 months. However, there was not an association with gait speed. It ended up attenuating when you took other factors into account with adjustment. Whereas widespread pain and the resting and recall pain measures were not significantly related with any of the outcomes. So that led us to believe that our cross-sectional work was steering us in the right direction, because that's pretty much what we found before. So it was really an extension of previous findings, and it gave us a better sense that this movement evoked pain construct is meaningful clinically, but also as far as research goes, it's something that we should be investing resources in.
So take us to the moment when you all, when the analyses were done and you all shared this information. I mean, to me, this is a very meaningful finding, and which is one of the reasons I was so interested in your paper. I mean, were there some adult beverages shared on this one, or just what was the conversation like when you all found this out? It had to have some spark to it.
Yeah, no, you're definitely right. So in the study, you'll see that we thought that there would be this pretty clean gradation of findings, where movement evoked pain would be the most strongly related, then widespread would come in second as far as the strength of relationship. And then lastly, we figured resting and recall pain would be the least associated. So when we saw the findings related to resting and recall pain, we were not surprised. It was pretty much a ratification of what we found before. But we were definitely very surprised about widespread pain and the lack of relationship there, just because of, like you said, it's often linked, very consistently linked to worse outcomes. So it's not like we were feeling like we were entirely correct about our hypothesis or anything, or we were not overjoyed to see that there was a lack of relationship with widespread pain. It was more so this surprise, because as you mentioned, it's pretty long held that this type of pain presentation is an adverse impact on populations. So yeah, it was shocking to say the least, and it just kind of further solidified our thoughts that we need to really get a better sense of what's going on with movement evoked pain.
Thanks for that. And I know you're doing more work in the future on this, and I know that you don't have all the answers, but again, if you don't mind putting your clinician hat on, and let's say you identify movement evoked pain at baseline, and you know that it potential has a negative prognostic factor, how are you going to manage this person? What are some tips that you might be able to impart on our clinician listeners based on what you know right now, knowing that the study's continued work needs to be done?
Sure. So I think it's something that should be integrated into clinical practice. And although we don't have a direct or a complete picture of what's actually driving movement evoked pain, I don't think it really changes other assessments that you should be looking at. So in the context of chronic low back pain, you would still be going through joint mobility assessments, strength and endurance assessments, all of those things that you would still be looking at in this population. And you're trying to see what may or may not impact this instance of movement evoked pain. So it's pretty similar to other clinical routes, I would say, where there's a bit of trial and error, and you're trying to see what actually um, has a positive impact for a given person. So it's not as easy as saying, oh, they have a particular joint mobility restriction. If you do mobilizations, they will have less movement evoked pain. I wish it was that simple. We're a few years away from making that sort of declaration, but it's one of those things where if you find a given breadth of impairment, so let's say joint mobility impairment, weak or poorly controlled trunk musculature, weak hip musculature, which is actually pretty common in this geriatric chronic low back pain group, I would say that you should be addressing all those multifaceted impairments and then thereafter seeing if it influences movement evoked pain at all.
Okay. So what's next? I mean, as a researcher, what are the gaps? Which direction do you think people need to go to further understand this? If you could wave a magic wand to dictate what needs to be done, what would it be?
That is a tough one. I think there are a lot of avenues that are still underexplored. So I think the obvious places to start would be to look at more longitudinal consequences, kind of like our study did, but either in a larger population of older adults with chronic low back pain, but also I'm gathering that same sort of information in knee osteoarthritis, hip osteoarthritis, those sorts of populations. As far as the lesser explored avenues, I think there's some really interesting work being done by Corey Simon and others where they're looking at stress reactivity. So the easiest way to think about this is that somebody may or may not be more heavily influenced by the immune responses of stress. So in the context of movement evoked pain, if they have these amplified stress responses, there will be changes in their blood inflammatory biomarkers, which can then amplify this experience of movement evoked pain. So in a simpler way, it's essentially identifying these phenotypes that might be more highly susceptible to movement evoked pain and disability. And it's looking at, again, that neuroimmune interface, and it changes your blood biomarkers. So I think that's a really interesting and potentially fruitful area. Another one that I can think of off the top of my head is looking at the brain or cortical responses to movement evoked pain. Now, as far as I know, there's not been a lot of work in this area, but the study that I'm thinking of most immediately here is from Dr. Stephen Coombs and his group at the University of Florida. So they used EEG in conjunction with a reaching task in a young to middle-aged chronic low back pain cohort. And they were trying to identify these specific patterns that might occur while somebody experience, excuse me, let me get one drink of water. Sorry about that. My apologies. So they were using EEG while going through a reaching task, and they were trying to identify these specific patterns that might occur while individuals also feel movement evoked pain. So I think that's another fairly unexplored but potentially important area, because if we're able to better understand the neurobiology, that might shed some insight on the influences and underpinnings that we should be addressing with treatments.
Yeah, I really like that. The fact that you take it back to its actual mechanisms and exploring the phenotypes with those. True translational research. Love that suggestion. So I'll get you out on this one, Pat. During the process of research, and a lot of people that haven't been involved in research don't understand how long it takes. And there are these golden moments, there are these epiphanies, there are these events that people go through that, change the way they think. Can you share any of those, or something that happened during this process that really sticks out to you?
Yeah, so the interesting thing is that this, of course, occurred during my PhD training. So I got the obvious insight of learning about getting a research project from the generation of the idea all the way through to published manuscripts. So that was, of course, insightful. But as it relates to movement evoked pain, I think I was just really shocked at how unique this construct could be, because it's easy to think that, oh, if somebody has high resting pain, they are immediately going to have worse movement evoked pain, which is not necessarily the case. And also, as we mentioned, it seems to be pretty distinct from other types of pain, like the spatial distribution, which would be widespread pain. how pain might feel in a qualitative sense, so whether it's burning or aching. So it's just really opening up this whole world in my mind of how we actually conceptualize pain and how we better identify it, of course, in hopes of developing new treatments that are targeted and also efficacious. So just really was kind of shocking all the way around to understand that there's this new conceptualization that really needs to be further studied.
Brilliant. So Pat, thanks for being on Shop Talk. I really like the direction you're going. I love the work that you've done. Greatly appreciate you sharing your work.
Oh, thank you so much for having me. It was a real pleasure. I enjoyed this.